Hello, I'm Lisa Martin from HORIBA Veterinary, and I'm delighted to welcome you to our Continuing Professional Development webinar. Although you may not have heard of us before, HORIBA Veterinary provide a wide range of in-house laboratory diagnostic equipment, from small animal to equine and farm work. HORIBA Veterinary have a comprehensive range from handheld meters measuring single parameters to benchtop systems capable of running over 400 tests per hour. Our LAPA range can accurately measure ionised calcium in blood in seconds and can be used patient-side. This incredibly useful tool aids in the detection of subclinical hypercalcemia in dairy cattle, which can affect yield, post-calving recovery and even future fertility. We also offer a wet clinical chemistry system with onboard refrigeration, which covers a wide range of parameters for day-to-day testing and beyond, including electrolytes, metabolic indicators and inflammatory markers, including acute phase proteins. Our Pocket Central PCR Analyzer. This is a benchtop instrument which even the smallest veterinary laboratory can accommodate. Its automated process allows you to save time on PCR testing with no need to wait for a lab pickup or for results to come back. If you have any questions about our webinar today, we'll be having a Q&A session after the webinar has finished. Please put your questions into the chat and we will answer as many of your queries as possible. Good evening. Hello, I'm Lisa Martin from HORIBA Veterinary, part of HORIBA Medical. Really happy to see you all here this evening. Thank you so much for joining us. I'm sure you've all had a very busy day already. I know just how pushed you are in practice at the moment. So thank you very much for taking the time to join us this evening. This is our second CPD webinar. We'll shortly be hearing from Ronnie Barron, who's waiting patiently in the wings. I know that this is going to be an informative and entertaining talk and very interesting for our attendees. We've got people joining us from the UK, from Europe, and I know we have some attendees from India as well, and we're very pleased to have you all join us this evening. Our first presentation in this short series of CPD webinars around testing for parasites in imported dogs is still available to watch on the HORIBA Veterinary website if you didn't catch it first time around. So a little bit about HORIBA first before we move on to the presentation from Ronnie this evening. You may not have heard of HORIBA too much before, but we have been in the testing and scientific market since 1945. And the HORIBA family are very much involved with the running of a family business. We have divisions in automotive testing, so checking on emissions from cars and other outputs, for environmental testing, air and water, for example, scientific testing. We have a semiconductor division, and obviously we're part of the medical division. And we supply analyzers for biochemistry, for hemostasis, and other things. We have our new PCR analyzer as well, used both in the human and the veterinary fields quite extensively. And the analyzers range from very small handheld devices to very large track systems capable of testing hundreds of samples per hour, both in the NHS and the private fields for humans. And in the veterinary business, we work with private practices, with external laboratories, reference labs, and charities as well. All of these establishments obviously have very strict quality control procedures in place, and HORIBA are very pleased to have been working with them. We'll move on to a little bit about Ronnie today, who I know is going to give a fantastic presentation. Ronnie's the laboratory manager of the clinical pathology section of the Veterinary Diagnostic Service at the University of Glasgow Veterinary School. After training in human haematology and blood transfusion serology, he was employed as a research technician involved in feline leukemia virus research, particularly in cellular vaccine projects. He has overlapping involvement in a variety of research projects supporting numerous interns, residents and research staff to gain professional qualifications and to be published. Interaction with clinicians within the vet school and wider first opinion practice has also been a large part of his activity, with CPD teaching of vets, nurses, technicians, both in the UK and abroad. He's been involved over the years with developers and suppliers of lab analyzers in both advisory and highly collaborative research and development roles. Ronnie has worked with HORIBA for a number of years and has helped to provide very useful insights on our analyzers. So he has a very, very good pedigree, and I know that he's a really entertaining speaker as well. He's got a great depth of knowledge, both technically and practically too. As mentioned in the video, Ronnie's very happy to answer questions after the presentation is finished. We'll all be muted during the presentation, but there should be a chat function on your screen, sorry, a question function on your screen. So if you do have any questions, please pop them in the chat and we'll run through them afterwards. So I'd like to hand over to Ronnie. Thank you very much.
Thank you, Lisa, and good evening, everybody. Now, here we are. Thank you. Sorry about that. I'm still sitting in the office of the lab in Glasgow tonight because the weather's been so bad that I wasn't sure how long it would take me to get home. So it's nice to be here, and nice that many people have turned up. The title, Beyond the Pale, was just to kind of put it into perspective. You guys have the patient, and beyond the pale was just after your clinical exam and your history and all the details you take that you then kindly share with us in the lab. If you refer samples, that's what happens thereafter. Now, the dog in the original advertised picture was extremely pale. This one's pale, but maybe not quite so white. So, humans have had a fascination for blood for centuries. Fairly recently, there's Hannibal Lecter. He had quite a taste for blood, but he usually liked it within tissue. So, within liver, with a nice glass of Chianti. Count Dracula on the other side, who preferred to do his venipunctures himself. And late in the 19th century, we started looking at blood cells and developing some of the techniques that we use nowadays to stain blood cells. And we're still using technology in staining that's very, very similar to what people used way back then. And I guess if it ain't broke, don't fix it. The history of diagnostics and using blood goes way back to the ancient Greeks, and they were interested in the four humours of blood, which they would take blood samples and look at it when it clotted, see what the colour of the plasma or the serum was, what buffy coat looked like, and what the red cell layer looked like, and equated it to these four humours. They would then treat people, whether they had success or not, it's very, very doubtful when we see how far diagnostics and treatments have advanced nowadays. It was one of the first tissues ever to be biopsied, and we're actually taking a biopsy when we take a blood sample, and probably one of the first to be transplanted, apart from, well, maybe skin grafting by seeding normal skin onto open wounds. It all starts with you guys when you have that patient, and unlike with humans, you're dealing with all of these different animal species, and there's so many different sizes of patients that you're used to seeing and taking blood samples. So appropriate needle gauge, I'm kind of teaching my grannies to suck eggs, as the Scottish expression. But as big a needle as one can get away with, given the size of the vessel that you're bleeding the animal through. Tripotassium EDTA is the best option for most species, and always check the volume in the tube. EDTA is an osmotic agent, so high concentrations of EDTA will cause shrinkage sometimes and cause hemolysis of red cells. Adequate mixing, there are a set of notes available, which are a set of foundation notes that can be sent to you if you contact HORIBA if interested, covering a lot of what we talk about in this presentation and some chemistry considerations as well. Complete inversion of your blood sample once you've added the blood. The lid's on, of course. Avoid creating any froth, because if you create froth, kind of like the head on a pint of beer, that's where platelets tend to aggregate and get trapped in there. And once they go into primary aggregation, then there's a good chance, if there's any tissue thromboplastin been taken in the draw, then a clot can develop. So always critical to have a visual inspection of your sample. If there's a big clot, just by tilting it, you'll see the clot move inside the sample. If you have a suspicion, but you're not sure you've seen anything, then taking a plain plastic tube and just gently decanting the blood into that, you should pick up on smaller clots. First things first, and before you go anywhere near anything else, make a blood smear from your blood as freshly as possible. So we use twin frosted slides so we can write the patient details on. One of the things my students always want to do is pre-label the slides before they make the smear, which when they have 30 or 40 smears thrown away by me because they're not up to scratch, they realise the futility of pre-labeling slides. The other good point about pre-labeling slides is that if you pre-label things and then you get called away, there's always a chance that somebody else using the same workspace could wrongly use one of your slides that's pre-labeled. Now, if that happens, your sample integrity is up the spout. So spreader slightly narrower than the slide we're spreading onto. A capillary tube with blood, 2/3 filled. Transfer a small drop on. Angle of your spreader is between 30 and 45 degrees and just smoothly spread out. And you should have something like this. Now, the major aim is to have all areas of the smear examinable so that if there's any abnormal cells at the edges, at the head of the smear even, very often platelet aggregates will hang up near the drop, or they may be at the feathered edge. So availability, and I think this is my technician Kenny's hands, and he does it the same every time. So it's muscle memory. Considerations when you're making blood smears is when you draw it into your capillary, you are actually being a human viscometer. Very watery blood from very anemic patients, you're going to have to increase the speed of spreading. Very thick blood, like hemoconcentrated animals, you're going to spread very, very slowly. So we're always trying to make our blood smears monolayers so that we can have a decent view of well spread cells. If animals are very anemic, sometimes it's worth considering making a squash prep. Now, squash preps made like this, same slides, but not with a spreader. You're going to use another clean slide, and a lot of you will have made tissue squash preps, and it's really as simple as that. It's just to draw the top slide along and end up with a nice oval so you don't have a feathered edge. We find that when we have anemic animals, we tend to get more neutrophils going down towards the tail of wedge smears. So sometimes we'll get better distribution using the squash prep. And we're finding lately that we've been doing quite a lot of work for aquaculture, that making blood smears from fish blood, squash preps like this are very, very useful. And as a comparison with the wedge smear. So, and for exotics, I would advocate you use both techniques. I'm getting ahead of myself. Once your smear is made, it really is essential that it's dried very, very quickly. Now, in the lab, we use an electric fan, just like a desk fan, and the whole procedure of making smears is done with the fan switched on the whole time on fairly high power. And when you dry blood on a glass slide, you're putting all of the cells through an increasing gradient of everything that's in the plasma. So all the electrolytes, the proteins, the enzymes, everything. Now, the one on the left here is one we had from a vet who's a friend of mine. I won't mention his name. I don't think he's in the audience though. And what he has done here has made this beautiful kind of Jack Frost type image of blood. And the one on the right is from the same sample. Now, it's fairly low magnification, but it's from an anemic dog, yet another pale dog. He's made his blood smear and he's put it into the container to post it before he's air dried it. So what's happened is it's dried very, very slowly in a very confined environment. And we get this beautiful crystallization of the red cells into multiple red cells, making nice needles there. The lab smear, on the other hand, it's an IMHA, this dog. It's regenerative. Even in low power, we can see polychromasia. We can see some spherocytes there, and we'll talk more about them a bit later. Now, abnormal morphology of red cells can have an effect on how they are sized through an analyzer. Now, this is a small near patient, or not near patient, but small backroom analyzer made by HORIBA. We have one we use as a backup analyzer in the lab. And it's very useful because very small sample volume needs to be aspirated. So if we're looking at mouse blood or very small animals, small samples from intensive care, then it gives us a fairly fast answer and reliable parameters for those that it does. But the whole point of making the smear is that we can see, and seeing is believing. So moving on. When you get to the stage of using the microscope and looking at the blood smear, we use a method that we affectionately call the oil slick method. Now, a lot of my students just naturally go and look at dry smears, and they'll scan it on the dry, and then they'll put a drop of oil on and use it times 100, and they'll bring a smear up to me and it's got one wee drop of oil on it. But this method lets you use, here we go, some oil, immersion oil, down at the tail of the smear. And this is just a hematocrit capillary tube, plain capillary tube. Smear the oil over the surface of the sample there on the slide. And what that does is give us this effect on the right here. So it gives us the same effect as having a mountain and a cover slip on the slide, but working in a laboratory where we're getting tens of samples at a time. Sometimes if somebody bleeds a herd of cows or has a research project going, it's not uncommon to get 20, 30 samples. And if we had to put cover slips on everything rapidly, then it would really slow things down. And we want to be able to see every blood, even though we have a machine that does an automated differential. So the left-hand side is before the blood smear had the oil put over it. And you'll see how we have this refractile image here, and the red cells and white cells look kind of like cartoon effect. And on the right, we've got the oil doing a marvellous job for us. So we have 4 neutrophils in that field there. I know we can still identify the neutrophils here, but we need to get a clearer view to see if anything's in neutrophils. Are there any changes? And when we're looking at the preservation of cells on blood smears, I read an ancient cytology book, and the author used the analogy of how eggs get damaged or get presented when you cook them. And these are just kind of like cells, where the yolk is like the nucleus within the cell and the white is like the cytoplasm. So we have fried eggs, 3 in a row there, but the one number 3 over here, the yolk has burst. And well, personally, being half Irish, I hate a burst yolk. So my fried egg's got to be intact. It's got to be cooked over the yolk. So here we have one that's not cooked over the yolk. So on your blood smears, you're seeing all of the details there if these were cells, but you might not be able to identify this one here. If you're further up the smear and thicker areas, your cells might look more like a presentation like a poached egg, which I love. And if they're coming across like scrambled eggs, you really are struggling to be able to identify anything. So when you get a blood smear, being systematic is the way to do it. If you have a system, a pro forma, if you like, or an SOP for how you do examine it, you want to see the whole smear. And that's why I was saying about the spreader being narrower than the slide that you spread onto, and all of the smear being examinable. And the way we do in Glasgow is we tend to look at platelets first. So we'll do the assessment of the platelets first. And we'll know that if we put a sample through an ABC or our big lab analyzer, which is an Advia, and lots of different analyzers are available now using various technologies, we get a number out, but until you look at the smear, you don't know that that number is absolutely reliable. And one very important thing to remember, in one species in particular, in cats, the platelets overlap in size with the red blood cells. And I don't think there is really an analyzer around that can accurately count cat platelets, because the other annoying thing they do, cats really are quite annoying wee devils. And I've known them when I used to bleed cats. I mean, they could disappear up the curtains like a shot. It's that platelets from cats aggregate in EDTA. So when you have a whole clump of platelets presented to the sensing system in your analyzer, it's not going to be able to count how many platelets are in that clump. So platelets looked at, red cell assessment second, you're looking at shape and size, you're comparing them with the white cells round about them, and then you're assessing the white cells third. This is, all of these are actually on a PDF that I'm sure Sarah has organised for you to have. So it's just an example of how some people use this method for assessing platelet numbers on blood smear examination. But remember, where you have clumps, either at the head of the smear or the feathered edge, then this technique is not going to work all that well, because you're really just assessing the free platelets. So it's a subjective look over the whole thing. But it's maybe not a bad thing for a quality assurance. If you're in doubt about your analyzer, you can do a rough check if the platelets are not aggregated. Now, being Scottish, well, half of my genes are Scottish and half are Irish, and us Scots are renowned for wanting a bargain. And free information is always great. So when you make a blood smear, The top one here is from a dog of mine several generations ago. The smear's upside down, and it's actually Charles is his name there. And that's a fairly normal looking smear. We'll maybe get a slight streak there, which probably is a little bit of rouleau formation. I don't remember why I bled him at that point. Excuse me. But this one down here, we're seeing this really weird distribution of the red cells. We've got a red band down here, and we've got a bluish band here. So free information there, and we suspect that this is what we had in the top smear there. Now, you'll say to me, polymorphs at the tail, but this guy's not a polymorph, and you'd be quite right. Although polymorphs do congregate round about the tail, this guy is a big reactive lymphoid cell, or he might even be a lymphoblast, and he's dragged to the tail. Down here, we have a mononuclear cell that's got very blue granules in it, and it's not actually a hemopoietic cell, it's a mast cell. And he was found down in the tail of the blood smear. The areas of the smear we want to be in the monolayer for doing differentials and for assessing red cell morphology. When you're right down at the tail, the red cells flatten too much. And in mammalian blood, we're aiming to have biconcave morphology, with the exception maybe of cats and the ruminants with very small red cells where they don't show a pale area. Your poached egg areas up here, and away up here, you're looking at the boiled egg area. And boiled eggs are great for histopathologists and the anatomics, because they'll cut a section of boiled egg and identify it. And down here in the tail as well, very often, and your previous webinar with HORIBA was blood parasites, and here we have a dirofilaria, and it was found on the tail of a smear. Platelet aggregates are the bane of the hematologist's life, and this is very often why we can't rely on the number coming from an analyzer. Here we've got a massive platelet aggregate, which has probably got, I don't know, 60, 70, 75 platelets within it. There's 2 or 3 free there. Red cells are looking pretty normal, not much regeneration there. Half a neutrophil here. I don't know why I took a half a neutrophil, but it's better than no neutrophil, one would say. Here we're on the feathered edge of a wedge smear where there's been absolutely massive amounts of platelet aggregation, and the patient, whoever he was, has probably got an increased platelet count, but difficult to assess when they're all in aggregates, because 90% of the smear may have no platelets on it whatsoever. And then we come to looking at breed peculiarities, and CKCS stands for Cavalier King Charles Spaniel, or as one of my technicians call them, King Chucks. And there are some Cavalier King Charleses, though not all, who just naturally have mega-sized platelets. Now this Cavalier here has platelets that are nearly the size of red blood cells. There's a smaller one down there. So this normal healthy dog had a platelet count that was in the 70s, and a reference range in Glasgow for dogs starts at 200. So he had a platelet count in the 70s, but his platelet volume was about 3 or 4 times the size of a normal non-big platelet dog. So his massive platelets was equivalent to, say, a Labrador with normal size platelets and a normal platelet count. We do see changes in platelet size when we get dysplastic change in bone marrow. Now, bone marrow is great, and I absolutely love looking at it, but a lot of people hate it, and anatomic pathologists hate it. But it's one of the reasons why humans evolved. Was Stone Age man developed the technique of being able to break bones to get into the highly nutritious bone marrow, and these would be carcasses probably killed by saber-toothed tigers or velociraptors or whatever. I'm no dinosaur expert, though, I must say. Now, this dog had really weird platelets. They are absolutely gigantic. If you look at the size of this one, use the red cells as a size measure, and dog red cells are maybe 5.5 to 6 microns in diameter. So there's 1, 2, 3, 4, 5, 6 and a bit red cell diameters to that one platelet. So we didn't have any history, and the clinicians in the vet school had it. They're not very good at filling in forms. They teach vets to go out into practice, but don't practice what they're preaching to people. So when we did find out that the dyspoetic changes in the marrow, and particularly in the platelet series coming from the megakaryocytes, was caused by an immune-mediated disease that was in the fat layers of this dog, and it had lesions. So when they treated the immune-mediated paniculitis or steatitis, it went back to normal, and the platelet production went back to normal. Now, considering this, when it goes through your analyzer, there is no way that any analyzer has a size window for counting platelets that will cope with these massive things. I mean, this big one here is kind of quarter the diameter of a megakaryocyte. Dogs with petechiation were really concentrating on platelets. Now, it's not a very dramatic blood smear. It's a little bit old, and we've got some spiking of the red cells. But remember, platelet assessment first. We know that there's manifestation of thrombocytopenia because we've got petechiation. And when we make a blood smear on this guy, we see no platelets. I don't see any whatsoever. The spiking of the red cells here is an artifact because it was a postal sample, and it's the effect of the EDTA causing the jaggy surfaces to the red cells. The target cells are probably an actual effect, and something's going on with this animal, because when it came to the vet school, it probably had a decent amount of steroids, but it still wasn't overcoming its thrombocytopenia. Here we've got a fragment of a red blood cell here. So thrombocytopenia, always check your sample for a clot. The most common cause of thrombocytopenia, as we see it in the lab, is a clot in a blood sample. Now, the clot might not just be obvious at the time of bleeding. I've had the conversation with several people over the years, and they said, but I checked it, it was fine. But coagulation is a dynamic process, and when you've taken your venipuncture and you may have a little bit of tissue thromboplastin in there, the coagulation cascade is activated, and that can be ongoing at a smaller rate because the EDTA has been binding off calcium ions, and the sample can develop half an hour later, an hour later. Sometimes we'll take a sample out the fridge the next day to do something, and it was liquid when it went in the fridge, but then it's clotted when it comes back out. Tying your platelet count to the clinical evidence for thrombocytopenia is useful as well. In fact, it's critical. But always remember that your results in hematology are only one time point. And hematology is really a very comparative science. So monitoring is always necessary, and especially in acute cases of thrombocytopenia. Nice normal red blood cells, just for anybody who just needs a wee refresher. This is from a dog. We've got nice platelets here. Variation in size in platelets. So in hematology and in hemopoietic tissue, when we produce mature cells. Generally, bigger cells are less mature unless there's something going on that's causing a macrocytic red cell to be produced as a mature red cell. So not a lot of variation in red cell size, not a lot of blue dye going into the red cells, a nice mature neutrophil here, fairly neutral cytoplasm. This was a little dog that had onion poisoning, and he had raided the bin of a commercial restaurant, an Italian restaurant, and I'm not exactly sure what he got to eat in vast quantity, but it certainly had a lot of onion in it, and he's producing these cells here which have a pale, very thin area. It looks as if somebody's pinched them, and they're called blister cells because if you saw them at the side, this end here would look almost like a spherocyte. There's no pale area in it. There's the squashed bit there. And these are evidence, particularly in the dog and humans, of oxidative damage of hemoglobin. Down here's a mechanically fragmented cell, and here's a nucleated red blood cell. So we're seeing normochromic red cells, we're seeing bigger immature red blood cells with what we call polychromasia. So it's taken both the acid and the basic dye into it. Another normoblast over here, and two pretty normal neutrophils there. When we look up close, we'll see another thing here, and this is what we call a Heinz body, named after Heinz and Ehrlich, goodness knows how long ago. Hematological manifestations get named after whoever discovered them, and the early ones were hematologists or pathologists, but actually dentists and subsequently surgeons. So that's a Heinz body there. We do, well, I do find with dogs in our country that they do clear the Heinz bodies in this type of hemolytic anemia very quickly, because dogs' spleens are really quite efficient. So again, here's the blister cell. Interestingly enough, the Australians have a different name for the blister cell. They call it the dangocyte. It's spelled as it sounds. Platelet size is increased here. We're seeing a bit of fragmentation in places, so there may be a bit of increased production of platelets. Here we're seeing a new methylene blue, which is what we use to stain reticulocytes. Now, in hematology, we talk about reticulocytes because the old-fashioned hematologists called collectively the organelles that supported the nucleus of the normoblast, or I think American terminology is rubrocyte and rubroblast. So endoplasmic reticulum, Golgi body, ribosomes, all of this has RNA in it, and it supravitally stains with new methylene blue, which is isosmotic, and we see these as stained reticulocytes. But one of the added benefits is the Heinz bodies, the denatured hemoglobin, the protein part of hemoglobin after the oxidative damage, we can see down here. There's some reticulum up here, there's a reticulocyte has ruptured. So this one was definitely an oxidative damage, and it was treated with antioxidants, and the anemia resolved, and the dog did quite well, and was never allowed near the dustbin at the Italian restaurant again. Different thing with the cats. Now, cats have what we call a non-sinusoidal spleen. So if you think of the spleen as the housekeeper for cleaning up the blood, this species has a very lazy housekeeper. Now, the image on the left is Romanowski stain, which we use May Grunwald Giemsa in our lab, but it's It's the same effect as you have in Diffquick, or you have in Leishman's, or you have in Wright stain. And we see the Heinz bodies here, and they negatively demonstrate. One of the big considerations for your analysis through the analyzer is that these little things will cause turbidity when the analyzer makes a lysed sample in order to measure the hemoglobin. So they scatter light. So they make the analyzer think that there's more hemoglobin there than there actually is. Again, we've used new methylene blue over here, and we can see them positively demonstrated. So in the olden days, what we would have done, we would have made a lysate to do a hemoglobin measurement, but we would have centrifuged it or filtered it to get rid of the Heinz bodies. Now, when you're looking at your CBC, and I'm assuming that everybody all has some degree of experience with hematology, but if anybody is lacking in experience, then please ask questions later or email. What will happen is when you have an artifactually high hemoglobin, then the hemoglobin-derived indices, mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration, will be increased. Now, because of the way that red cells are produced, physiologically, it's not possible for an animal, a mammal, to produce a very high MCHC. So if you flag a very high MCHC on your CBC, something artifactual is going on that measurement of hemoglobin. Now, the smears we saw earlier on, where we compared the normal one with the one that looked a bit like a fingernail, this is what we're seeing, and the red is the aggregates or agglutinates, more accurately, of the mature red blood cells. In between and towards the top of that smear, we're seeing the blue staining because of the reticulocytes and the white blood cells and the platelets. So we suspect that there's an antibody here against this dog's red blood cells, and it's causing agglutination. So we do the slide agglutination test, or I believe the Americans call it a saline dispersal test, which it's the same thing. Now, to do this, add about 3 drops of normal saline, which means it's isoosmotic, so it's got a concentration of approximately 0.9% sodium chloride in water. And then what I tend to do is mix the sample, take a hematocrit capillary, and then just touch it onto the surface of the saline. Now, anything you do serologically, it pays to always add cells last, because the old adage is gravity gets you down, and gravity is your friend in this occasion because it's dragging the red cells through your reagent. So if you were doing a test using an antiserum, you would always use red cells last so they fall through the reagent. This one's positive macroscopically, and we saw what it looked like under the microscope. Considerations for immune-mediated hemolysis, and we see 2 different types, but it is very important that when you have to transfuse these animals, you're not going to be able to do a cross-match, but you can use blood typing. So IMHA, if you have slide agglutination test positive, or if you have direct Coombs test positive, cross-matching is not applicable, because these antibodies are antibodies against dog red blood cells, no matter what group of dog red blood cells they are. But if you can give group-specific blood to your patient, then hopefully you're not raising an antibody against a DEA 1.1 positive if it's 1.1 negative dog, which may save for problems in the future. This is the IMHA with spherocytosis. So this would be the type of IMHA that we would use a direct Coombs test to demonstrate. And here we're seeing spherocytes. So if we looked at them side on, they would look the same as they do from above. We've got biconcave red cells there. We've also got a schistocyte there, a fragment of red blood cell. Platelets in between. Now, when we get immune-mediated hemolytic anemia, we get a kind of overall marrow response, but we also have triggers of inflammatory pathways, and thromboxane gets activated. So we very often have this blood picture with a lot of red cell regeneration, but it's also accompanied by a fairly good-going neutrophilia. And in hematology, hematologists love hemospeak, so the hematology name for that blood picture is leukoerythroblastic, which just means you've got a left shift of the neutrophils and you've got a left shift of the red blood cells. So agglutinating types tend to cause intravascular hemolysis, and you're more likely to see jaundice there, and your bilirubin could be up. Your plasma will look icteric. The spherocytic ones, because it's a sensitizing antibody, tend to have extravascular hemolysis. So the hemolysis is going on in the spleen, and the spleen is actually trying to pick the antibodies off the surfaces of the red blood cells. And the red blood cells are great things for resealing. I mean, we've seen quite a few schistocytes on the way to this stage of the presentation, and spherocytes tend to be a specific effect of sensitization, usually by immunoglobulin type G, and what we call as pitting of antibodies by macrophages. So slide agglutination test for the former, because it's a polymer antibody, not polymer. Yes, one's a monomer and one's a polymer. So the agglutinating ones will be IgA or IgM, and the spherocytic ones will be IgG probably. Now, some immune-mediated hemolytic anemias will have combinations of antibodies, so you could have different classes. You might have spherocytosis, and you may well have agglutination, which makes life even more complicated for you in assessing it, but never need a cross match. Another anemia, and I think, if I remember rightly, the advertised picture was a dog with iron deficiency anemia. And when anemia develops over a period of time, it's quite amazing how animals will still be up and about and on their feet, even though they're very, very anemic, because not all anemias just develop overnight. And even the immune-mediated ones, I've picked up on spherocytosis in dogs before they actually became anemic and was poo-pooed, and they did develop a more fulminant type of IMHA. So, staining reactions of blood cells, and this is what really makes it so satisfying, that you're using something from 1900 or before, and it uses a very basic technique that we have two dyes there. We have an acid dye and we have a basic dye, and in chemistry, as opposites attract. Even at my advanced years, I remember that from chemistry at school, and we'll get combination uptake. Sorry about that. With, where are we going? I beg your pardon. Combination uptake of the dyes, and that's what we see when we were talking about polychromasia earlier. And here we're seeing the blue cells, and this is right on the tail of the smear. And distribution of reticulocytes can be very skewed, and particularly in cats, and particularly in animals that have immune-mediated hemolytic anemia. Because if you reckon you've got agglutination going on, or you have spherocytosis and you have some normal red blood cells, it's kind of like raking leaves in the garden, making a blood smear sometimes. Advance. And again, here we're using new methylene blue stain, and this is a cat. And interestingly, cats, because they have this lazy type of spleen, the spleen cleans up reticulocytes and tidies them to become mature red blood cells. In cats, we have two stages of reticulocytes. We have the aggregate or mesh reticulocyte, where the reticulum is joined together, and then past that stage, we have these more punctate, stippled cells. So these ones are the most recent to come into the circulation, and the ones where we have the stipples have been in quite a bit longer. So when we tend to count reticulocyte counts in cats, we count really these heavy mesh ones rather than the stippled ones. Some people would advocate counting both and having a percentage for both, but I think life's too short for that. So absolute counts of reticulocytes are important. If you're getting a reticulocyte count from your analyzer, your blood smear examination is very important, because often in cats we will see that the immature red blood cells aggregate together, and they're seen in what look almost like agglutinates, but they're actually aggregates. There's no antibody involved in it. But I think it's the floppy immature red blood cells have a different zeta potential, so they are allowing themselves in vitro, when they cool down, to actually stick together. Absolute counts is the way that we use reticulocyte counts. We'll take the percentage from a smear estimation if we do it manually, and we'll apply that to the total red blood cell count and work out the absolute number of reticulocytes. And dogs and cats, I think dogs are 0.06 and cats are 0.05, or it might be the other way around. But it kind of depends on red cell lifespan, and expected red cell lifespan in a cat is about 80 days in the circulation, and a dog is about 100. And you and I, providing we're all healthy, should be about 120. So hematology really is all about supply and demand. If we're healthy, supply and demand are in balance, and hematologically unhealthy with anemia, then demand has increased and reticulocytes need to be counted. Different ways to look at them. A reticulocyte index, I've never actually used it, but I'm sure some of you will have. And here's our dog who's supplied the normal blood smear, and we don't have red blood cells, but we have a population of swans here, and we have some normochromic swans, and we have some polychromatic swans here. We've got a total population of 5, and we've got 3 polychromatic immature ones. So we have a percentage 3 of 5, 60%. So red cell regeneration, remember it's only one moment in time, which sounds quite lyrical. Retic response, remember your reticulocyte response takes a lag for it to come out from the bone marrow. So if you see something with an acute blood loss, you'll rebalance fluid levels, and reticulocytes won't be up at that stage. So it would be pre-regenerative at that stage. Polychromasia is the same thing as immature red blood cells, but some immature red blood cells won't show up as polychromatic cells. So that's why we need either a reticulocyte from your analyzer or from a new methylene blue. But in reality, the true measure of red cell regeneration is that the red cell numbers increase and hematocrit increases. Other things that will affect your red cell sizing when you're using your analyzer, no matter what type it is, and this is a feature we call poikilocytosis, or mechanical damage of red blood cells. Now, when your red cells circulate through your arteries, your veins, your venules, your capillaries, they don't circulate round as by concave discs, but they become like little cigar shapes. And so they go round corners, they go through vessels that are narrower than the diameter of the red blood cells in some species. Now, what's happening here in this cat is we have something circulatory that's causing distortion of the red blood cells. Now, the normal distortion caused by flow within vessels reverses, and when we take a sample and make a blood smear, we see our normal red cell morphology. But you stretch them far enough, they don't bounce back into shape. So mechanical damage here, and some of these arguably are fragments rather than whole red cells that are distorted. Now, this will really take your mean cell volume down in the analyzer, and your MCH, mean corpuscular hemoglobin, will drop down as well. You would hope that your MCHC is sticking at normal because you're producing enough hemoglobin inside the red blood cells. We'll see it where there's fibrin deposition. We'll also see it in hyperthyroid cats. We'll see it sometimes reported in a lot of hematology texts and hemangiosarcoma that you see schistocytes and things, but I've never seen a really markedly poikilocytosis picture in a hemangiosarcoma. Tumours where you're getting localized fibrin deposition, you may be getting necrosis in tumours. That effect would not be uncommon. Mycoplasma haemophilus, you should see it in your diff-quick. And down here, there's our friends, the Heinz bodies. This is a cat, of course. And normal cats have a few Heinz bodies anyway. So you would expect percentage of Heinz bodies to be low single figures usually. And when we produce a load of Heinz bodies in cats, we usually suspect something is going on in the gastrointestinal tract. Differential white cell counts. The method we use using the wedge blood smear is an extended battlement like this. Now this can be up and down the smear on the monolayer, or you can do it across the way as well. This one is the way when I went to college quite a few years ago, this kind of castellated thing, and I kept getting lost. So I adopted this one. And depending on distribution of cells on your smear, up and down is good, or side to side will do just as well. So when you get to the point that you've done your CBC and your analyzer, and you may be thinking, oh, I don't think that's right, because not all analyzers actually move their gates to accommodate subpopulations of white cells. So it might get it wrong. And it doesn't mean the analyzer is bad. It just means that your blood is abnormal. And if your near patient analyzer screens out 80% or 75% of your patients for pre-anesthetics as being normal and picks up a small percentage that are abnormal, and you think, well, that doesn't look right, I'm going to make a blood smear, I'm going to have a look at it. Although you should make a blood smear on everything, according to Ronnie. When you count your differential, if you get 200 cells, if it's a very low white cell count, you might struggle. Apply your percentage to the total white blood cell count and get your absolute number of each of the subtypes. And remember, reference ranges are just that. There's some mature normal white blood cells in a cat. Now, your hematology is your springboard into doing cytology. So actually appreciating what chromatin pattern is like in polymorphs. We have this lacy type chromatin pattern. And in lymphocytes, we have a kind of patchy, but a more filled in chromatin pattern. And then in monocytes, there's almost a fine line, and it's a paler chromatin pattern. Now, when people learn hematology and learn how to identify cells, a lot of people have problems with the monocytes. Now, a good trick is if you make your blood smear as soon as possible after taking your venipuncture, and you're having trouble identifying the monocytes, go back to your sample at that stage. Now your sample is maybe half an hour old or 3/4 of an hour old. It's probably somebody chuckling at the back and saying it's probably a day old by this stage. The longer it sits in EDTA, monocytes like to eat the EDTA, so they vacuolate more in EDTA. So making another smear and staining it, you can go and you can compare the two of them. And I almost bet a pound to a penny on your older blood sample smear, you're going to pick out the monocytes more easily. Eosinophils, similar chromatin pattern to the neutrophils. These needle-like granules are fairly typical in cats. And over here we have a basophil, and basophil granules tend to overlie the nucleus very often. So, and strangely in cats, we have this not very basophilic, but kind of lilac staining. So the surface of the granules may not let the blue dye in very well. And it kind of reminds me of school dinners. It kind of looks like tapioca pudding. In the dog, again, similar patterns. This monocyte I particularly like because he looks like the profile of a microscope here with the eyepieces. And there's the objective down there and the base with the light source. Dogs, basophils, they're very disappointing. And they have quite faint greyish granules. Eosinophils, very variable size granules. And you'll find that particularly in greyhounds. They have very kind of vacuolated backgrounds between the eosinophil granules. Monocyte again here, but distorted in amongst the red blood cells. So when you're interpreting your differential, think about how your neutrophils are produced, where you have a mitotic pool, maturation pool, and you have storage pools, all in the bone marrow. Then they get released and you have a circulating and a marginating pool. And then number 3, you have the tissue pool. Your tissue pool is usually very low, but then you have a dog that maybe has a pyometra or something like that. Your tissue pool increases. So that takes neutrophils from your circulating pool and your marginating pools and kicks off more release from your storage pool in the bone marrow and regulates your granular poiesis upwards. So your neutrophil count goes up, providing your tissue pool's not dragging too many in. Now, when that happens, we get this increase in production, and we tend to call this manifestation toxic change, and it's because there's this rapid production that we're not tidying up our neutrophils enough. And it's not actually because there's a toxin there. We're seeing rough endoplasmic reticulum in here, and the neutrophils are not as tidy. They maybe not been as long as a storage pool within the bone marrow. And we see these doly bodies. The lobes are a bit fatter as well, so they're probably a little bit less mature, even though they're segmented. This animal, though, has a lot of spiculing on the red blood cells. It's uniform, so uniform spiculing on fresh red blood cells, if you've dried them properly, indicates something's awry with your plasma. And in this cat, I think it had a bacterial peritonitis and it was hypoalbuminemic. So that's why the red blood cells were spiky. Left shift, we're about banned neutrophil stage here, and again we have the toxic change. It's the same animal. The sharp-eyed of you will be spotting Heinz bodies here. It may well be that it's dehydrated. Breed peculiarities in the cat. We have Birman cats. Some, I think nearly all Birman cats, I may be wrong, and crossed Birman cats have this very pronounced granulation here, which is not toxic change, and really quite pretty. This is an acute lymphoblastic leukemia. Now, this will have a white cell count that is maybe 150 times 10 to the 9 per litre when your upper end of your white blood cell range is somewhere about 12 or 13. So it's 10 times what it should be. But this is something that will cause an artifact in your hemoglobin measurement in just about any analyzer. So anything that's causing an artifact in hemoglobin, rely on hematocrit. If you're worried, spin a hematocrit on something you're not sure about. It costs very little to do, and practically everybody has a microhematocrit centrifuge. This one here is a different cell line, and we've got the granulocyte cell line, and we have blasts over here, a little bit advanced further than blasts. We're going down to fat bands of metamyelocytes and myelocytes. So we have a granulocytic leukemia or acute myeloid leukemia, which has maturation. These things you're not going to see all that often, but if you see features on a blood smear that tie together, you're kind of tracing a pathway. Similar type thing, but this is a monocytic leukemia, and there were blasts in the circulation and mature monocytes in the circulation. Any monocytic leukemias I've seen in dogs and cats have had a very poor prognosis. In cat, we've got loads and loads of eosinophils, and it's a hypereosinophilic syndrome, or is it a chronic granulocytic leukemia with eosinophilic maturation? Both things would have intestinal lesions or infiltrates. Maybe they both are the same thing. Erythroleukemia, we don't see it very often, but we tend to see bizarre granulocyte precursors. This is a myeloblast over here and up here and here, and then we have the nucleated red cell series, and we're seeing the tail end of it there. Here's a binucleated immature red blood cell, and there's one quite distorted. We're not seeing a lot of polychromasia relative to the number of normoblasts in the circulation. Other leukemias, basophilic leukemia, I have never seen a leukemia with basophils, but people report basophilic leukemias when we have mast cells in the circulation. So another Scottish, I beg your pardon, what's going on? Another Scottish expression is as rare as hen's teeth. And remember diff quick. Why did I tell myself that? I told myself that because some mast cells don't stain very well in diff quick. And here we have mast cells in the tail of a smear, and this animal's got a systemic mastocytosis, or mast cell leukemia, some people call it. Here's this manifestation in diff quick, and I've seen it in a couple of cases over the years where clinicians have sent up aspirates that they have stained themselves with diff quick, and there's the one on the left. It's very difficult to see the granules. We can probably see some there, and there's an eosinophil as a clue, but you can get them where you see no granules whatsoever. But the chromatin pattern of mast cells is kind of similar to lymphoid cells. Nuclear cytoplasmic ratio is kind of like histiocytic cells, but the shape of them is all wrong. So you suspect I've got to go and do a Romanowski, and when you stain the same thing, there you get the granules. So assessing all of these features of cells, red cells, platelets, casting doubts on abnormal results coming through your analyzer and being suspicious is natural. When you look at cells, making an identikit to identify the cells is a very important aspect of hematology, and this is a tortoise. We used to have a few tortoises within, I think we probably still do, for the students to learn handling techniques of the exotic species. So we'll get normal heterophil here, and this fella here is slightly less mature, but the same cell line, red cells in the background. And now here we're looking at some vacuolation in the background. We're looking at some bluish staining behind the granulation of the heterophils. And here we're thinking about toxic change. And true enough, what we had an egg peritonitis in this tortoise. So our exotics clinicians operated and opened its abdomen and dealt with the peritonitis, and then resealed it using car body filler, I think is the way of the world. And I can get a thank you in at the end of this part of the evening. And the patients are key to the whole thing. I mean, we're very fortunate that we have vets taking samples from various species, and it certainly enriches what we do in the lab. I wouldn't be able to do what I do in the lab or come and show you nice pictures of things if it wasn't for my staff in the lab and all of the clinicians I've worked with over the years in clinical work and research work. And most especially thank you to yourselves for being here tonight, and to HORIBA UK for hosting and spreading the hematological word. And I think at this point, Lisa will be taking over.
Hi, Ronnie. Yes, thanks very much for that. Such a lot to take in there, and it's a subject that you're clearly very passionate about and also very knowledgeable about. I've been sitting here making notes myself. I'm not working in practice any longer, but when we speak to people about haematology every day, it's very useful not only to just have a refresher on the basics, but some of the more technical points that you've made as well. You know, the hints about taking your smear as quickly as possible, how to get a good smear, which I know I learned a really long time ago, but hearing about that again was incredibly helpful. I'll never I think look at a smear again without thinking of eggs now, whether they're poached or fried or something else. So that was really helpful. Your hints about transfusion medicine as well. So for anybody that's working in practice that has to think about transfusions, the practical hints about those I think are incredibly useful, because it's something where if it goes right, it's great. If it doesn't go right, then you've got problems. So those handy hints about transfusion were good. Remembering that haematology is just a snapshot of what's going on exactly at the time, and obviously there's a lag between what you'll see in a sample and what's going on in the bone marrow, and keeping a monitor, a track on things is so helpful. And the other thing for me was about reticulocyte counts. It's something that we get asked about a lot with analyzers. So whether your machine has got a reticulocyte count on it or not, there's definitely no substitute for having a look down a microscope and seeing what's there. And if you're not confident about doing it yourself, send it into your reference lab and let one of the experts have a look. They're always very happy to help. So I know that there will be some other questions that will crop up as well. We've had a couple that have come through on the chat, so we'll keep an eye on those. If there's anybody that's listening in, then please feel free to pop your questions in the chat there. We'll be relaying them to Ronnie just now. So just seeing what's come up already. When it comes to using automated analyzers, Ronnie, for haematology, what's your recommendation regarding QC procedures? I know that in the external lab you'll have to perform them very frequently for your accreditations, but in general practice, what's the feeling about that, and what's the best process to use?
My feeling, Lisa, and everybody else, is that looking after your QC material is one of the critical things. And very occasionally I'll be in, well, not very occasionally, over the years, quite a few times, been invited to practices to go and actually teach people with their own equipment. And there's been the odd time that they store their QC material on the windowsill, which is not a good idea. It's better kept in the fridge. When you take it out, let it get to room temperature. I think for most analyzers, you should be checking it once a day at the very least. And if you are using other methods like cross-checking hematocrits, using repeat analysis, so if you run a sample in a dog or a cat in the morning, it doesn't cost you a lot in most things to run it again in the afternoon and make sure the thing is stable, it's reproducing the proper numbers. Your results from your quality control material fit in within the range, acceptable range that the producer is giving you. Pay attention to open vial stability of these things. The insert in the box will tell you how long it's good for. If you have a problem with an analyzer and you're maybe using the QC material more often, if you have a suspicion, then run it again in the afternoon. And if you're using that one vial of material repeatedly, then things start looking a bit weird in it. Think, is it that the control material is actually going off? It doesn't last forever, and you should have other vials as a reserve there. So your stock of QC materials has got to be planned well in advance.
Sure. Okay, that's useful. Obviously, as HORIBA, we provide QC material with reference ranges, and I'm sure that anybody who's using another haematology analyzer will have the same. And obviously, when you're using an automatic machine, you need to make sure that the results that you're getting are correct. We don't all have Ronnie's experience and the ability to know what's right and what's not. So to make sure you're getting your good results, make sure your QC procedures are followed strictly. Another question that's come through as well is in relation to using analyzers for looking at other fluids. So whether practice might be doing a tracheal wash, peritoneal samples, or maybe a joint sample. Any thoughts about that, please, Ronnie?
Yeah, synovial fluids are a thing that we frequently do, but we will pre-treat them with enzymes. We treat them with hyaluronidase, and it makes the sample less viscous and frees up the cells so that you can count them electronically. And we had a student a few years ago who did a project in this, looking at cat effusions, abdominal and peritoneal, using hyaluronidase. And in these types of conditions, whether it's FIP in the cat or whether it's other inflammatory conditions, we tend to see white blood cells aggregating together. Using the enzyme, it separates them, and then we have free floating single cells. You'll have a dilution factor. I think the factor we use at the moment is 50-50 enzyme to fluid, and then it's just counted through the analyzer as a normal blood would be, but you would just multiply the nucleated cell count, the red blood cell count, and the hemoglobin by 2, and again, compare it to the smear of your fluid, wherever that fluid's coming from. The big one to be aware of when using an analyzer to count fluids would be CSFs. Now, even though your analyzer has a very low background, just running plain diluent through it on a cycle, it's still its background for a white blood cell count would probably be tipping into the clinically abnormal range for a nucleated cell count in a CSF. So it's only very sophisticated analyzers that can actually cope with CSF. In fact, in my lab, we don't use an analyzer for CSF. We will use counting chambers, and we'll use Fuchs-Rosenthal counting chamber. We'll put a thick cover slip on it and charge mixed CSF into that, and then count it in phase contrast in the microscope to determine how many red cells and how many white cells are in there.
Okay, that's really helpful, thank you. I know that where practices are using analyzers for fluids other than blood, that the dilution using the hyaluronic acid is a handy hint, and also make sure you clean your analyzer really well afterwards before you put anything else through it.
Yes.
And another really good hint actually with your CSF as well. So when we talk about making sure that your readings are correct by running your QC procedures, make sure that you get a blank as well. I know with our machines that it will run a blank cycle first thing, and as part of your QC process is making sure that everything is clean and not having any debris in the tubes will be conducive to getting good results out again. I know that there was a question from one of my colleagues, Paul. I don't know if he's going to put that in the chat or if he'd like to
I've got a question.
Here we are.
Thank you, Lisa. Hello, Ron. Hi, Ron. Your presentations are always the same. They're always very original, very informative, and highly entertaining. So thank you very much for that one as well. I wanted to ask firstly, of all the samples that you see going through the lab, Ron, what kind of percentage would you say were due to parasitic infections? Just a rough idea. I know it's a hard question to answer.
In our lab, I would say it's way less than 1%, Paul.
Is it? Right. Okay.
It's not in ruminants. We are seeing mycoplasmas or hemoplasmas in sheep and in cattle, and we do see Mycoplasma felis or Hemoplasma felis in the cats. And only once have I seen the equivalent thing in a dog in the past 10 years. But we're not a real kind of cross section of the public, and it's kind of changed a bit as well, because first opinion practice has become phagocytosed by the corporates, and they all have association to their own labs. So I don't see so many first opinion cases hematologically as we used to do years ago. So that may well be quite different now. So there was a couple of delegates from Axiom Laboratories, and they will be looking at a relatively higher percentage of first opinion stuff. And as well as that, in Scotland, we're kind of further away from the channel. Things coming in, though we have seen diarrhea, we have seen leishmaniasis. In a cow, I had a very interesting case where I diagnosed trypanosomiasis, and interestingly enough, that diagnosis was only made because I had to teach a resident how to make impression smears of tissue. And interesting calf, it was born and developed very severe anemia. And should I have my camera on, Lisa?
You can do, Ronnie. Yeah. We're very happy to see you again.
I'm still hearing a recording of me. And this calf had a really profound anemia. And we looked at it and we thought, is it like horses, it's isoerythrolysis, that there's an antibody in the milk that it's drinking and it's lies in the red blood cells, but there was nothing we could detect. And we looked at bone marrow in this animal and we couldn't find anything except that it was profoundly anemic and it had a sort of dysplastic maturation process going on in its bone marrow, but it wasn't neoplastic. And it was only when I took impression smears of liver and spleen that we actually found trypanosomes in there. And the trypanosome was Trypanosoma tyleri, which is generally non-pathogenic in cattle, but very occasionally, and I think in traumatic births, it can be passed from the dam to the calf transplacentally at partum, and this is what had happened. I think it had been a particularly traumatic delivery as well, and a combination of things. So it was actually the animal was in being PM'd, and there was nothing you could see that gave you any clue on any of the histology. You couldn't detect them, but you could detect them on the impression smears of the liver and the spleen. And then we went back to the bone marrow and examined about 30 or 40 smears and found they were in there as well.
Interesting. Yeah. I
That's
see there's a
amazing.
question in there now, Lisa, from someone else.
Absolutely, yeah. Thank you, and thanks for that answer, Ronnie. That's really interesting.
Yeah, thank you, Ron.
Another question that's come in. So this is a comment as well. Nice to see tortoise cells included in your talk. So if I can ask you this in the interests of being fair, so I think it's the question directed at HORIBA, but in more general terms as well. Does this mean that your machines can recognise with nucleated red blood cells separate to white blood cells? So if you can answer that in general terms for me, Ronnie, I'd appreciate it.
We're
Ronnie,
still at the stage
in
in hematological analysis that testing.
Oh, got you. Thank you.
Okay, sorry about that. I don't know what happened. We're still at the stage with exotics, and at the moment we're doing a lot of work for aquaculture and looking at salmon blood and lumpfish blood, and we use manual techniques. Now, if the questioner has any need for technique assistance or anything, then happy to send information on email. But it still is very laborious compared to mammalian hematology. I know that years ago Abbott Diagnostics had said that they were able to adjust Celldyne 3500 to give certain parameters, aspirate blood into that, a large, basically flow cytometry and impedance analyzer. But my experience so far is, yes, you can get a total cell count, and that's about it. And depending on the sizing gates, whether it actually deals with the size of cells, because with lizards and snakes, tortoises, amphibians and fish, the red blood cells are pretty big, and thrombocytes are nucleated and white blood cells are nucleated. It's still a frustration. I wish I had more time to develop something, or somebody interested in inventing HORIBA, for example, and develop analyzer for exotic species. I would be
We've noted it, Ron.
I'd be happy to lend a hand with that. How quick it would take, I don't know. It needs some serious financial backing.
Indeed, indeed.
Can I just ask you another question, Ron? Not really a hematology question, but related. I mean, I know you're a human. You worked in a human hospital, didn't you, first as a hematologist, a human lab. What inspired you to become a veterinary hematologist? Hello?
Yeah, I think, Paul, I was young, and I had one kid at that stage, and my network's going very slow, Paul.
Yes, it's okay. I can say that.
Me? Hello? Network's going. I'm back again. Sorry, network's going very slowly here. It's done well up until now, but the university is probably turning the lights off or something and causing interference. I found being in the health service, it tended to be a bit like a factory, and we were just hammering through thousands and thousands of hematologies every day. I was spending hours going and taking blood samples from pregnant ladies, nothing to do hemoglobins on, and anticoagulant clinics, taking samples to do thrombo tests. And when I saw the opportunity to go to Glasgow and actually work in a research project that involved hematology, that was meant to be a kind of short-term interlude in my career. But then when I took over the hematology lab, and then subsequently we created clinical pathology, it kind of pinned me down. And I mean, that's how you and I met, was me in that position, consulting for a research and development school. The ankle thing attached to me, that whenever I go through the gate, it sets off an alarm, and security are scrambled to get me back in again.
I think we've lost
But it's been interesting, and I think maybe, have you lost me again? Sorry.
Ronnie, I think we are struggling a little bit with your connection there, unless you're just really tired. It keeps going very slowly. I know that you've had a full day in the lab today as well, so a little bit of lag, either electronically or physically, is definitely excused. So we've come to 9 o'clock now, which was our scheduled time to close.
I've lost you as well.
I can't hear anything from Ronnie now. I think we may be drawing to a close. I can still just about see you there. So again, huge thank you to Ronnie. We really appreciate the time you've taken to put the presentation together and to talk to our attendees this evening. On your screen, you should be. Oh, I've just had one more question come through, a comment. Thank you. I'll just run through that. So it says, I'm inspired as a hematologist with keen interest in morphology. It's one of our HORIBA colleagues, but this has been a fascinating talk. Thank you. So this is another defector from the human side, working in a lab, who's now taken an interest in veterinary hematology, but she's working for our medical team. So thank you, Kelly. That's lovely to get that feedback from you. And I know that you're passionate about hematology and morphology as well, so it's great that you found this interesting. So for everybody that's watching in, you should have a holding slide there with the details for Paul and myself, our contact details. If you do have any questions for us or for Ronnie as well, his details are at the bottom of the screen. You're very welcome to contact us. Ronnie's very kindly allowed us to share his email address with you. There's also a set of notes that he's put together in relation to haematology. It's quite a weighty document with some really good handy hints, and you're welcome to have that to refer to afterwards. And
happy to answer anybody's
Oh, slight interruption from Ronnie's audio there. So Ronnie's very happy to answer questions, and his notes will be available via email. You'll get a follow-up email to thank you for attending on the night, or if you weren't able to attend live, also to access the notes via that route too. So thank you for everybody that's joined us again after a long day, and we will be having another CPD webinar. We're scheduling our next one for January. If you have any hot topics that you would like us to talk about in relation to lab diagnostics, then please feel free to email and let us know. We will be at London Vet Show very soon. Really looking forward to being back out and seeing our clients, customers again. We've attended the Equine Show earlier this year, and it was really nice to be seeing people and to see all of the safeguards that they put in place to make sure that those attending in person are very well looked after. So if you're coming to the London Vet Show, please come and see us on the HORIBA stand. And I think that's it. So I'm really sorry that we've lost Ronnie from the screen. I was really looking forward to saying that it's good night from him and it's good night from me. So enjoy the rest of your evening, everybody, and thank you again for joining us.